Nobody tells you this about bipolar disorder. The dangerous part isn't the sadness, it's the days you actually feel incredible. The confidence, the energy, sleeping 3 hours and getting more done than everyone else around you. It doesn't feel like a symptom. It feels like the best version of you. And that is exactly why it gets missed for years. Meanwhile, we throw the word bipolar around like it's nothing. Oh, the weather is so bipolar. Your ex was totally bipolar. You had a good morning and a rough afternoon, so you say to yourself, I must be bipolar today. But mood swings and bipolar disorder are not the same thing. And confusing them is dangerous in both directions. It turns a serious illness into a punchline, and it leaves the people who actually have it undiagnosed while their life quietly comes apart. So here's what nobody spells out for you. What bipolar actually is versus what everyone thinks it is. The myth, the reality, the biology, and the part you never see coming. Stay till the end. I'll give you real tools that you can use, and remember, there is hope. If you're new to my channel, hi, I'm Dr. Nikki, a registered psychotherapist with over 20 years of experience treating individuals who struggle with complex mental illness. I'm here to share my knowledge, answer your questions, and help you sharpen your critical thinking skills so you can make wiser decisions and take back control of your life. Bipolar disorder might be the most misunderstood diagnosis there is. Exploring information on the internet can leave you feeling more confused than enlightened. Some people believe it to mean moody, and for others, they picture someone flipping from ecstatic to sobbing in an afternoon. Both are wrong, and both are why real people go years without the help that would change everything. So here's where this is going. By the end of this video, you'll be able to tell the difference between ordinary mood swings and actual bipolar symptoms. You'll understand the two different types, the biology underneath, including genetics, the brain, the body clock. You'll also see the part almost nobody talks about, which are the personality patterns that can ride on top of it and what it feels like on the inside. You'll know how it's actually treated, and you'll walk away with practical strategies and something to hold on to when it does get hard. Hold this in your mind. Bipolar disorder is not a character flaw. It's not too many feelings. It's a treatable illness. You stabilize the biology with the right medical care, and then in therapy, you heal the patterns underneath. The ones that taught you to keep moving so you'd never have to feel. That's how you stop white knuckling through episodes and start building a life that's steady and actually yours. Hope is not lost. Remember, hold on to that. Everything I'm about to show you leads straight back to this. Let's now start with the biggest myth. Bipolar disorder is not rapid mood switching throughout the day. If your mood dips after a fight and lifts when you make up, that's not bipolar disorder. That's being a human being reacting to your life. The reality, bipolar runs in episodes. It's episodic, distinct stretches of time, usually days or weeks, where your mood, energy, sleep, thinking, and behavior all shift together and stay shifted, not just for an afternoon. And often, it isn't even triggered by anything. It can just come out of nowhere. That's the tell. Normal mood swings are about something and they pass. Bipolar episodes take over, they last, and they change how you function. An episode can either go up or down. So let's talk about the up. Let's talk about mania. Mania is not just feeling extra happy and very excited about the day, kind of high on life. A manic episode is a distinct period of at least 1 week or any length if it lands you in the hospital. And this involves abnormal, elevated, or irritable mood, plus a real jump in energy and activity with a specific package of symptoms. Here's the line that matters. A manic episode causes serious impairment or requires hospitalization or comes with psychosis, such as losing touch with your reality. Hypomania is a milder version. Like a Diet Coke version of mania, this type of mania lasts at least 4 days, and it is not severe enough to significantly impact your life functioning, and there's no psychosis. It's a clear, observable change from your normal self. So whether it's mania or hypomania, there's a distinct change in your thought patterns, your behavior, your sleep patterns, maybe your appetite patterns, your relationships, impulsivity, risk-taking. You shift and you stay shifted. So here's why hypomania, for example, gets missed and it can be romanticized. Because it can feel amazing. You feel confident, creative, unstoppable, sleeping 3 hours and crushing it. So people don't report it. It's the people around you who notice these symptoms before you do, such as noticing the impulsivity or your more risky behavior. Nobody calls a doctor because they're feeling incredible. That's exactly why bipolar hides. The up doesn't feel like a symptom. It feels like the best version of you. In the other direction, we have a major depressive episode. So this is the downfall from mania. Remember how I was saying it's episodic? So there's an episode of mania or hypomania, and then there's the downfall. Depressive episodes include 5 or more symptoms over at least 2-week period, with at least one symptom being low mood or loss of pleasure. Other symptoms include exhaustion, sleeping too much or too little, worthlessness, trouble thinking or deciding, appetite changes, and sometimes thoughts of death. And here's where it turns dangerous in a way you rarely hear. Most people with bipolar disorder come in for the depression because the highs never feel like a problem. If the mania in their history gets missed, then they only get treated for plain depression. And an antidepressant on its own can flip a vulnerable person into mania. For example, selective serotonin reuptake inhibitors, SSRIs, can trigger a manic episode. That's why the full picture, the ups and the downs, is the difference between treatment that helps and treatment that harms. The two types of bipolar disorder come down to how high the up goes. Bipolar 1 requires at least one full manic episode in your lifetime. You don't even need a depressive episode for the diagnosis, though most people have them. Bipolar 2 requires at least one hypomanic episode and at least one major depressive episode, but never a full manic one. So now you can go ahead and bury this myth. Bipolar 2 is not in its entirety bipolar light. So when I was talking about hypomania being like a Diet Coke version of mania, I was talking about the symptoms of mania. The depression piece in bipolar 2 often are longer and more disabling. There are milder highs, but that doesn't mean a milder illness. So that's an important distinction to make. Everything I just gave you is a framework, not a self-diagnostic tool. So recognizing yourself in this list is not a diagnosis. Bipolar disorder is genuinely hard to diagnose. On average, it can take years because the highs get missed and it masquerades as plain depression. So only a licensed clinician, such as a psychiatrist or clinical psychologist, can diagnose this because they rule out everything else, like thyroid issues, medications, substance use, or other conditions. So if this sounds like you, that's not the verdict. It's a reason to book a proper assessment, especially if you believe your symptoms are impacting your daily ability to function. You may need medication for stabilization, so it might be best to reach out to a psychiatrist. The difference between moody and bipolar disorder isn't how intense it feels. It's whether it comes in episodes, how long they last, whether they hijack your sleep, energy, and judgment, and whether they show up even when life is going well. So where does it come from? To understand it, we must look at the biology first, and then a psychological layer most videos never touch. I have to correct the biggest myth and most harmful myth right here. Bipolar disorder is not only caused by trauma, and it's definitely not a character weakness. There is a major influential factor that must be discussed, and this is the biological component of bipolar disorder, which was not discussed in my previous video, but deserves attention. Let's begin with the genes. In twin studies, heritability estimates for bipolar disorder run as high as 85 to 90%. If you have a parent or a sibling diagnosed with bipolar disorder, then your risk is roughly around 5 to 10% versus about the 1% in general population, which is several times higher. It's polygenic. So not one bipolar gene, but many small effect genes stacking up, and it shares genetic roots with schizophrenia. This is also why your healthcare professional needs to rule out schizophrenia if you also have symptoms of psychosis in addition to symptoms of depression, hypomania, or mania. The bipolar brain also looks a little different on average, and I want to be precise. These are group-level findings with small effect sizes. There's no brain scan that diagnoses you, but across the largest studies, the pattern is consistent, which includes reduced gray matter in the prefrontal cortex, which is essentially the brain's brake pedal, responsible for judgment and impulse control, alongside a more reactive amygdala, which is the emotional gas pedal. Not to mention the difference in the anterior cingulate cortex, the hippocampus, larger ventricles, and the white matter wiring that connects these regions. Picture it as a powerful engine with weaker brakes. When the prefrontal cortex can't fully rein in the limbic system, mood and energy can accelerate or crash harder than they ever should. Here's the piece almost no one explains. Deep in the hypothalamus sits the suprachiasmatic nucleus, the SCN, which is your body's master clock. It keeps your sleep-wake cycle, your hormones, and your daily rhythm on a roughly 24-hour beat. In bipolar disorder, the whole circadian system runs dysregulated, shifted, or completely out of sync. And researchers consider this so core to the illness, they've proposed it as a trait marker. It's tied up to clock genes, like a clock, and to an enzyme that helps run that clock. This is why sleep isn't just a symptom of bipolar disorder. Losing it can trigger the next episode. Protecting your sleep and your daily rhythm is not a lifestyle tip. For you, it's medicine. And here's why it can be helpful. Lithium, the golden standard of bipolar medication, acts partly on the same enzyme. The biology and the treatment meet at the clock. There's also the chemistry. But let me bury another myth. Bipolar disorder is not a simple chemical imbalance. It's a dysregulation across several systems. Dopamine running high in mania and low in depression, that's the drive and reward switch. Plus, serotonin, norepinephrine, and the glutamate GABA balance that sets the brain's overall excitability. It's not one dial turned just a little too far, but a whole orchestra is out of tune. Which is why the medical treatment is different from ordinary depression. The foundation is usually a mood stabilizer, lithium is the classic, and it's also one of the few medications shown to reduce suicide risk. Alongside it, prescribers use certain anticonvulsants, which were developed for seizures but also stabilize mood. And sometimes atypical antipsychotics are used for acute episodes or long-term stability. This is exactly why an antidepressant by itself can be the wrong vehicle for treatment. Medication for bipolar disorder isn't the easy way out, and it isn't a moral failure. For most people, it's the floor everything else gets built on. You stabilize the biology first, then the deeper work becomes possible. Always talk to your prescriber and your pharmacist about side effects and interactions, especially if you are taking lithium. Pharmacists are incredible. They are underused resources, so definitely use them to further your knowledge. So that's the illness. But for many people, there's a psychological layer that can ride on top. And I have to be precise because this is where everyone gets confused. The biological components of bipolar disorder are treated medically, but underneath, there's often underlying unconscious driving factors that influence your bipolar symptoms, which stem from childhood trauma. This is psychic trauma and or classic trauma. Whether you are consciously aware of it or not, this is actually empowering because this means you can begin to process your deep-rooted pain in therapy. That this isn't a fixed lifetime sentence. So let's dive in and understand the psychoanalytic perspective in a little more detail. In my depression series, I talk about the depressive personality structure, the person carrying a quiet, bone-deep belief, something about me is bad. It comes up as guilt. If people really knew me, they'd leave me, and or emptiness. Something's missing and I can't name it. The psychoanalytic defense is introjection, taking a critical parent's voice and making it your own and turning it against you, aiming inward relationally. These are often the kindest, most sacrificing people in the room. And if that's new to you, watch the series first. I'll link the full playlist below. And if the depressive side is hitting you a little too close to home, I made something just for you. My mini course, Unmasking Your Depression, lives inside the Mind People community and it's completely free. It walks you through exactly what I just described: the guilt, the emptiness, the inner critic in your own voice, and how to start working with it. Grab it after this video. The link will be right down below. Now stay with me, because here's where it gets fascinating. Now we are diving into the psychoanalytic perspective of the manic personality structure, as outlined by Nancy McWilliams in her book, Psychoanalytic Diagnosis. Mania is the flip side of depression. Point for point, it's the mirror image. The same underlying pain met with the opposite coping strategy. Traits such as the hypomanic character is overly bright, funny, magnetic, high energy, very social, articulate, idealizing, work addicted, always on. But underneath, though, is the guilt, difficulty truly resting, difficulty being alone. And when the negative feelings break through, it tends to come out not just as sadness, but anger. There are many defenses when it comes to the manic personality structure, but in this video, I'll talk about two. One being denial. So basically shooing the problem away by turning anything painful into a joke, a plan, a project, and acting out, usually as flight, literally running away from situations that threaten potential relational loss. There's also the second defense, which is devaluation, dismissing the very people that you fear getting close to. So the one part of the psyche wants to get close to people, but the other keeps people at arm's length. One of Nancy McWilliams' patients called herself a spinning top. She had to keep moving because the second she stopped, she'd feel something that she couldn't emotionally bear. For the relational component, the pattern is fear of attachment. To love someone is to risk a loss that would be devastating. Because remember, we can either move away or inevitably pass away. So the detachment is very difficult. So individuals are charming up front, but not deeply connected. And you might be the type of person to bolt before it actually gets real, as a means to protect yourself. So you find that your friends adore you, but it's more surface level because they also quietly worry about you without really getting to know the depth of you. Where does it come from? In these histories, you often find repeated losses that were never mourned, death, divorces, moves, disappearances that nobody named or grieved. So maybe your parents told you that your family pet moved away, went to a farm, and is now living on that farm, when in reality, your family pet actually passed away. But maybe your parents didn't want you going through that pain. So over time, you learn not to stop, don't attach, things can get too hard, don't let people in. Because if you let people in, if you let loved ones in, loved pets in, then the risk of them going away is too much. It'll break you. So you do your best to protect yourself. But ultimately, it's not serving you well. Essentially, the constant motion is also a way of outrunning the biggest crisis a person can face. That we inevitably die. That we're ultimately alone in our own experience. That no one hands us a ready-made purpose. Mania keeps you too fast to feel any of it. People with this pattern are often the most charming in the room, but the charm is a defense, and beneath it is far more suffering and far more fragility than anyone could ever expect. And this is why I take the highs as serious as the lows. That keep moving, keep shining defense can hold right up until a loss becomes too big to outrun. Then it can collapse fast into a crash, into despair, sometimes into suicidal thinking that seems to come from absolutely nowhere. When someone who's always fine, always up, always the strong one, suddenly isn't, that's not drama. That's not a mood swing. That's the defense failing. That's the moment you need to lean in, not step back. Stress, sleep loss, substance use, and the big upheavals don't cause bipolar symptoms. They're triggers. They light the match in someone who already has the wiring. And childhood adversity raises the risk and can worsen the course. You didn't give this to yourself. This is not your fault. But it is your responsibility to get support. And you can't personality flaw your way in or out of it. But you can learn what sets your episodes off. And protecting your sleep, your rhythms, and your stress load is one of the most basic things that you can do to help improve your overall mental health. Remember when we talked about stabilization? Stabilization We need to stabilize the biology, right? Through, let's say, medication. Then heal the patterns underneath. That's the order. So here's what works based on the research. First, the medical foundation for stabilization to help increase your functionality. Then the deeper work to process the deep-rooted pain. For bipolar disorder, medication is the foundation. Full stop. This is also a biological illness, and it's treated medically first. Mood stabilizers, anticonvulsants, and sometimes antipsychotics, which are managed by appropriate and competent healthcare professionals, such as a psychiatrist, to diagnose and provide medication, and a psychotherapist like myself who specializes in treating the clinical disorder like bipolar disorder. Together, this can aid in your treatment process and overall progress. This is the start of your circle of care. This is what keeps you safe and helps you heal. I do have to say this though. Medication alone often isn't enough. And this is the good news most people never hear. The research is clear. Medication plus therapy beats medication alone. There are specific evidence-based therapies for bipolar disorder. I will briefly list the standard treatment approaches therapists use when treating those diagnosed with bipolar disorder. Now, these approaches, in my professional opinion, begin to build the foundation for deeper psychoanalytic work. 1, psychoeducation. Learning about your illness, your triggers, emotion identification, and your early warning signs so you can catch an episode before it catches you. 2, CBT, spotting and correcting the distorted thinking that fuels both the highs and the lows. 3, dialectical behavioral therapy, or DBT. These skills, mindfulness, distress tolerance, and emotion regulation for the moments that feel unbearable. 4, family-focused therapies. Because bipolar disorder happens in relationships, and the people around you can either steady you or destabilize you. So family therapy for loved ones can be an essential part of treatment. 5, IPSRT. Interpersonal and social rhythm therapy. This treatment is built specifically for bipolar disorder. It stabilizes your daily rhythms, sleep, meals, activity to protect the body clock, the SCN that we talked about. These aren't positive thinking. These are skills that hold your stability in place. And paired with medication, they can help you recover faster and stay well longer. Even though the standard treatment approaches can be helpful, that is only part of the therapeutic treatment. There's deeper work, and this is where we treat the personality structure, not just the symptoms of the disorder, because stabilizing your moods doesn't automatically undo a lifetime of not being able to process your deep-rooted pain over the years. Psychoanalytic psychotherapy, done alongside your medical care, does a few specific things that are vital to your treatment. 1, it makes the unconscious conscious. We name the pattern out loud. I keep moving so I never have to feel. You can't change what you cannot see. 2, it does the mourning that you never got to do. So those unmourned losses underneath the mania, we finally get to grieve them in therapy, slowly and safely. That's the core of the work. 3, it prevents flight. It teaches you to stay grounded. Having that said, it's my job as a therapist to help my patients understand their desire to bolt treatment prematurely. So we practice staying in the room, in the feeling, in the relationship, long enough to help the patient learn that attachment doesn't have to end in devastation. Your emotions are not too big and will not destroy your therapist. 4, it answers the existential questions instead of burying them into the unconscious. With insights from people like Viktor Frankl, who founded this insight inside a concentration camp, you learn you can't always choose what happens to you, but you can always choose your stance towards it. Meaning isn't something you wait to receive like a package in the mail. It's something you build, one genuine choice at a time. You don't have to keep spinning to stay safe. When you can finally slow down and feel the grief you've been outrunning and survive it, you don't need the mania to protect you anymore. You can do it all on your own. And because bipolar disorder carries one of the highest suicide risks in mental health, far above the general population, I need to say this directly. If you're in that place right now, or someone you love is there, please don't carry it alone. In Canada and the US, call or text 988. Anywhere in the world, go to findahelpline.com. Reaching out is not a weakness. It's the bravest thing you can do for yourself and the greatest gift you can give yourself. Here's what I need you to actually hear. Bipolar disorder is one of the most treatable conditions in mental health. Treated well, people don't just survive it, they build full, stable, creative, deeply meaningful lives, careers, marriages, art, families. Like I said, it's not a life sentence. It's a condition you manage, and management gets easier, not harder, with time and with the right support. The version of you in the middle of an episode is not the final version of you. It is a chapter, and you get to write the next one. None of the patterns underneath are who you genuinely are. They're who you learn to be, a conditioned response built by losses you were never helped to carry. And anything that was learned can be examined, questioned, and slowly unlearned. You don't have to keep running. You can be still and safe at the same time. Here's what you can do starting right now. These are educational and practical tools that you can use to help you grow. Remember, this is not therapy and it's not a replacement for therapy. Tip number 1, track your mood and your sleep daily. A simple 1 to 10 mood rating and the hours of sleep every single day. This is called a mood chart, and it's how you and your care team can spot patterns that catch episodes early. Sleep is your dashboard warning light, so watch it. Tip number 2, protect your rhythm. Same wake time, same bedtime, same-ish meal times every single day. Weekends included. You're stabilizing that body clock on purpose. Guard your sleep like it's the medicine that it is. Tip number 3, map your early warning signs. Everyone has a personal tell that an episode is coming, needing less sleep, spending more, talking faster, or sinking into withdrawal. Write yours down while you're well, so future you can recognize them. Number 4, build a staying well plan. A 1-page, my early warning signs, what I'll do when I notice them, who I'll tell, and my crisis numbers. Share it with 1 or 2 trusted people and your prescriber. Number 5, tell 1 or 2 people that you trust. Pick someone who can gently say things like, hey, I'm noticing the signs. You can't always see your own rising episode, so let somebody else help, such as a spouse or a loved one close to you, lives with you, or someone that interacts with you on a regular basis. Number 6, go easy on alcohol and recreational substances. They destabilize mood and interact with your medication. Number 7, in a journal, finish this sentence honestly. When I can't slow down, what am I actually running from? You don't have to solve it, just start naming it. Naming is where healing begins. Use free association by freely articulating what fluidly comes to mind. You don't need to force it, just sit with your thoughts and see what comes up. You don't have to do all 7 tasks today. Pick one, gain momentum, and see what really speaks to you, and then try out some others. And if something works for you or doesn't work for you, leave a comment down below and share your experience. Now, moving on to affirmations. This is powerful because you are rewriting what you say to yourself. The more you identify the reasons why you are so amazing, the more in which the part of your psyche that loves you for being you will grow. That's the part that we are watering, nurturing, and wanting to see flourish. Now, I want you to say these with me and save them for a hard day as well. This is an illness I have. It's not my forever self. My worst episode is not my final chapter. Getting help is strength, not weakness. I can build a steady, meaningful life. People do this every day. So can I. I'm allowed to feel the grief I've been outrunning. It will not destroy me. Stability is not boring. Stability is freedom. I don't have to keep spinning to be safe. I'm worth the work of getting well. I am worth loving myself. Even if everything else was a blur, remember this. If you have bipolar disorder, you are not dramatic. You are not too much, and you did not do this to yourself. You have a real treatable illness and a self that is so worth getting to know. And if the word bipolar was only ever a joke to you, Now you know the truth behind it. Maybe you'll use it differently. Maybe you'll spot it in someone you love in time to help. Remember, bipolar disorder is not a character flaw, and it is not too many feelings. It's a treatable medical illness. You stabilize the biology with the right medical care, and then in therapy, you heal the patterns underneath. The ones that taught you to keep moving so you'd never have to feel. That's how you stop white knuckling through episodes and start building a life steady that's actually yours. Hope is not lost. It's within your grasp. That's the whole map. It's not hard to conceptualize, but it is hard to walk the path. And the first step is just an honest look at what's really going on. If you really want help with your bipolar symptoms, then the only way out is in. If this information has resonated with you, then here's your next move. If you think bipolar disorder or bipolar-like symptoms might be part of your story, the first step is to call your family doctor or preferably a psychiatrist, because a diagnosis and medication are the first step towards stabilization. Without stabilization, you cannot do the deeper work. And once you're getting that care, or if you're already stable and ready for the deeper work, that's where my team comes in. We provide therapy, specialized therapy, alongside your medical team to help you understand the patterns, protect your stability, and build that life that you actually want. So if you're in Ontario, book a 30-minute complimentary consultation with our consultation care coordinators. There's no pressure, no commitment, just a conversation to see if we're the right fit for you. I've mentioned this before, but I will say it again because it is so important. If you're in a crisis or thinking about suicide, reach out now. It's free, confidential, anytime. Canada, the US, call or text 988. Anywhere else in the world, go to findahelpline.com. Reaching out is not weakness. It is the bravest thing that you can do for yourself. And this also builds that self-love that you were talking about. If this video gave you language for something you couldn't name, then save it for later, click the like button, and send it to someone who needs it as well. Drop a comment about what myths about bipolar disorder you used to believe. I'll do my best to read and respond to all comments, and don't forget to follow for more honest mental health insights that the majority of professionals won't or just can't tell you.